timely and accessible, which deal with emergency issues and urgent care issues, and integrated and continuous that deal with caring for people in different sites and situations and different caregivers caring for them and how we link them all up, and efficient indicators to make sure that we are not redoing testing and referrals unnecessarily because we haven't bothered to collect and organize things properly within our practice. So in fact, they're all linked up. And we use, in fact, someone from England wrote to me and said, can we call your program the Sunflower Program? So we chose a sunflower a long time ago as a kind of metaphor for what we're doing, very dependent on being nurtured, good ground, good soil, lots of water, lots of sun. And if you don't give it all of that all of the time, it kind of fades. And we put our categories into purple petals, and we chose purple because nothing goes with purple. It's a really complex color. It's something that you grow into with time. You don't kind of understand it at the beginning, except little girls understand it. But generally, it's not a color that's well accepted, and it's a complex color, and it's probably a metaphor for all the challenges we have in practice. It doesn't quite fit in, but when you sort it out, it fits in very well. And we have 5 values, principles that support our program, most that are in a circle around it, and we have maintained those right from the beginning, and that came out of a lot of joint work that we did with various stakeholders in our organization. One of the challenges is that the word accreditation is not acceptable to family doctors in Ontario. They are completely threatened by it. They regard it as the government coming into their work. It undermines their autonomy. It undermines their pride. I don't understand it, but we could never use the word accreditation. So we use the word assessment and evaluation, and that seems to be okay.
It's amazing because I was in a conference in England and they asked who has negative feelings about assessment, and all the hands went up, you see. So
So we call it a voluntary program. Initially, we used the term consumer, and we've had a lot of pushback around using the word consumer because consumer in the healthcare field is not the kind of person and is more an industrial or corporate view of how medicine is applied. It's not advocates for large changes that we're looking at. It's rather advocates of our own patients that will help us do a better job for our practices. So there's a lot of language around patient and consumer. We have interdisciplinary teams. Our transformation of primary care has been to shift from individuals to team practices. So this is really a full team assessment. We use a continuous quality improvement model, and we use a self-reflection model. So it's really based not on some set standards and benchmarks, but on the self-identification of problems within the practice and aspiration to an improvement that they choose, not that's independent and separate. In time, there may be an independent benchmark that's set up. There already are in chronic disease management, but for many of these issues, it's really a question of the practice coming to an agreement about where they are and where they should be. So any questions about that somehow?
You didn't include workload and job stress as a sort of a think that you measure
We do.
Oh, you do?
In our appropriate practice resources,
Yes.
there is workplace improvement. I'm just trying to remember what it is. The practice team members balance work and home life.
I saw that, yeah, but there's not a sort of a validated questionnaire so that you can measure them and see them and have some reference to.
There is a validated questionnaire in that section,
Okay.
which is a link that we would have in that
So
section
you have a link to the web.
to the web.
That's
and
quite
I'll show
good
you that.
because then you can do it anonymously, which is
Yes,
important. Yeah.
yes. Well, no, we don't have the questionnaires set up so that they can link them. We don't have any organization to review the questionnaires, and
But do they get a reference? To
that
how
they get a
read?
reference how to
Okay,
do it,
yeah.
and that can help them do it. So,
Sure.
so this is the same as we have over here. This is what you have in black and white over there, and I have this in Portuguese for Brazil. Yeah.
But you have only the scheme, or you have, have you done the translation only for this general?
No, only this. And with my slides in Portuguese. Not these slides, the ones for Brazil.
And what about indicators about continual medical education?
Yes, so those are also included in the appropriate resources. We have a model which we call the quality cube, where each individual has to meet their requirements by their college, because if you're a nurse you have different requirements to a social worker, to a family physician, and the family physician model is that you have to meet your continuous professional development credits. The program itself is credited. If you do the program, you get all the credits you need for your continuous professional development. So as an incentive, the program provides the credits for people. So I don't know if over time it'll be retained once everyone is accredited. We probably will have special areas that they get credits for. But right now, if they did this program, not only do they get credits to retain their accreditation and license, but they get credits at the level of a fellowship, which is the higher level of credits for our college.
Does that include any more pay or
No,
no?
no,
It's just,
we've kept away from any pay for performance stuff. We did pay the practices. We do think the point you raised yesterday, we do think that there needs to be funding to support the quality activities. We did pay the practices in the initial pilots to participate in quality improvement circles and activities. And we're not quite sure whether that was a good thing or a bad thing from our evaluation of it.
Okay, I'm intrigued, because why would it not be good to compensate them for all the efforts?
In our province, you get compensated for all of your continuing medical education activities. You get $100 for every
Hour
hour of credit that you did. So they already get money for participating in something that they were, so there was a duplication there, first of all. But secondly, they didn't quite know how to handle the money. It took them a while to think, oh, there's enough money here to increase the hours of one of our administrative staff to assist us, or this money could support some professional development of some of the people in the practice. Our practices are not yet in the learning circle environment in which they know how to use that administrative time effectively. So I think we would need to do some training and capacity building so that they know how to utilize the resources. All we did was give them $5,000 and say, your practice will get $5,000 for joining the pilot project.
Well, this is quite a common problem, that people they start complaining that they're very busy instead of that they think, how can I delegate more so that I can do these things, you see, and it's somehow they're blocked in this sort of
And it's got to be part of getting started
Yeah.
and frequently asked questions, and there's got to be a resource for them that can assist them in how to use it. So this is just a summary of that other document that I showed you of the Institute of Medicine. So that's a basic background of the book. Now, I'll just give you a little overview of some of the elements of the book that you might find interesting. First of all, Richard Brawl came and spent a week with us, and we've developed a toolkit of Richard Brawl's key messages as a means of explaining to people the challenges associated with quality. And these are his 10 messages that we have, and our toolkit has a little two-pager that describes his background and what he's done in this area. It has 4 sets of slides, all using a different method. Some of them are a circular thing, some of them are a triangular thing. There's this one which are pointed points about what he does, and they all explode into individual slides that explain all of these 10 points. So, leadership is essential, teamwork is necessary, a bottom-up, top-down approach. Can't have one without the other, you've got to have both included in. All of those messages that are so key can help with the frustrations people have about not having a breakthrough immediately when they're working in their quality work. And a lot of the work that we're doing is trying to build leadership capacity so that the people, some of our practices have 100 family doctors in it, and so we need some leaders to help move those 100 family doctors together. So we've developed this toolkit to help us with this whole process. And this is the classic AA mill joke about not having enough time to do quality. Here is Edward Bear coming downstairs now, bump, bump, bump on the back of his head behind Christopher Robin. It is, as far as he knows, the only way of coming downstairs, but sometimes he feels that there really is another way, if only he could stop bumping for a moment and think of it. So we do use a CQI approach, and this is a little joke about CQI. It's just a hunch, but I think we could improve the process, how you get from one step to another. In our book, we have these diagrams, which we have developed, 3 of them. We also have a set of slides that we have attached, we're going to have on our website. So people can actually use our slides for teaching about our book, and all of our slides have copyright. People ask about copyright. We have open source copyright and official copyright, and we'll come to it a little bit later because I'll describe it in more detail. But we've tried to be very careful about the whole copyright process. And so we plan to have a website. We plan to have our slides on the website. And we also plan to do some webinars, international webinars and national webinars with Canadian doctors right across the country and internationally with people who are interested in using our book. And then to post the webinars on our website so that people can look at it asynchronously. And we plan to use a social media format like a blog, where people can write back to us any questions that they have about the use of the book in order to continue to improve it. We'll come to that in a moment. So here we use Don Berwick's PDSA cycles.
Was it Deming? The guy?
What's that?
Deming had the PDSA sales circle. Berwick was the quality guru, but I thought it was Deming. I'm pretty sure.
It
In
may be
Holland,
Deming.
it's the
That was
Deming circle.
him. This is his circle, and this is where it came from.
Deming said the plan to check act. This is plan to study act.
Yeah.
Oh, well, yeah, that could be the slide. Everybody talks in Holland about the Deming circle, so that's why.
Yeah.
But